Un, deux. So your presentation is ready, and you just one click, and after that you can check.
Okay, great. So I just click on that one I want to start. Yeah. Okay. And this is on. This will be on.
The microphone to speak.
Okay.
Hello?
Yeah.
Test, test.
Yes, it's okay. But you are sitting there, right?
Two things. One,
Your Excellencies, ladies and gentlemen, yes, please. So you're welcome to this workshop on WHO clinical trial resolution, better evidence, a stronger ecosystem. Leading us on this very session will be no other but Dr. Vasi Mothi, whom I think does not need a very long introduction to most of you. But for the benefit of a few that I think may not know him, Vasi Mothi is a senior advisor for health research in WHO Geneva. He has a long research tradition and profile, especially on clinical trials. And he has the passion to bring the best way of research that can improve health outcomes locally, globally, and especially for the developing countries. On the assumption of office of Dr. Tedros, he established the science division, and VASI since then has been working in that science division, coordinating and driving research for health, particularly for clinical trials. And since the adoption of World Health Assembly Resolution 75.8, May 2022 last year, VASI has also coordinated the response to the demands of that resolution, which was to get member states to strengthen clinical trials, all over. And in doing that, he has engaged in consultations with different regions to get the views and perspectives of every region as they pertain to ways or guidance that will be developed and shared with member states for strengthening clinical trials. And I think today this is what VASI wants to share with us. He wants to share the preliminary findings from these consultations. And on that note, ladies and gentlemen, I want to invite Dr. Vasi Mothi to take the floor. Please put your hands together for him.
Thank you so much, Joseph. Thank you to EDCTP for inviting me, and to Joseph for introducing me. It's such a privilege to be here. I started my life as a malaria vaccine researcher, so just seeing the progress in malaria vaccines and with EDCTP over the last 20 years is really absolutely remarkable. And meeting those of you who are younger than me, researchers, seeing what an exciting environment it is now. So I would just like to go through some background, just in case anybody is not aware of the background to this resolution. Does this work? I don't like to just stand in one place. So if I say next slide, will you be able to advance the next slide? If not, I'll have to go back. So I think that that's the high-level point. If I say next slide, will you be able to do the next slide, or do I need to do it? No. Okay, no, he's saying no. I don't know if anybody knows does everybody know what the World Health Assembly is? Is there anybody who doesn't know what the World Health Assembly is? I just want to make sure we're all on the same page. So this is where the ministries of health from all of your countries go to World Health Organization headquarters in Geneva, and they tell us what to do, because all we are servants, are the secretariat of the function of what all of the ministries of health, the governments around the world, including representing the needs of researchers, etc. We do what they tell us to do. So they adopt resolutions. Most of these resolutions are usually not on research, they're on implementation of public health programs. So it's very rare that we have a research-specific resolution. The last time there was a clinical trials resolution was in 2005, which is what led to the whole basis of trials transparency. Universal trial registration came out of the fact that everybody came together and said, we need to know prospectively what trials are happening and that the results should be disclosed. So this is the first time we have come back and had a resolution specifically on clinical trials. And the reason, as with much else politically, what's been happening at the moment is of course it relates to the pandemic. So I'm just going to go through the background, some mapping that they asked us to do, normative guidance development, key themes emerging from all of the consultations that have occurred as part of the normative guidance development and next steps. So the background to the resolution is, if you look at where we have guidelines, policy recommendations, we have a grade system that you're hopefully all familiar with, and as part of that we have what is considered to be high quality or high certainty evidence. Where we have high certainty evidence, it's almost always based on randomized clinical trial data. And here, this is from the COVID-19 Therapeutics Living Guideline that was coming out and being updated during the pandemic. And this is just the extract where we have strong recommendations either in favor or against. That's going to be based on clinical trial data. So this is what we want. We want pretty good confidence that something either should be used or shouldn't be used. And the high-level sort of message that really is behind the resolution is that there were a few trials that really were very important in rapidly generating compelling, good quality evidence that changed global practice, and you could argue, I think, legitimately save millions of lives, particularly the cheap, affordable intervention of dexamethasone or glucocorticoids that was identified by the UK recovery trial and was able to be implemented very quickly, basically everywhere around the world. Probably save millions of lives, but there were also many other very important trials. However, these trials that were useful were a very small proportion of the total numbers of trials. We have EDCTP, which is our aggregation site at WHO. We received over 20,000 clinical trial records, and that some of those are duplicates. There's probably about 15,000 actual clinical trials of COVID-19. Of those, certainly less than 10%, perhaps about 1%, really were useful for decision making. There were a lot of small, poor quality trials. And this is a graph from a publication that was published while these trials were underway, a lot of them, saying before they even completed that most of them were not going to be helpful. This is an analysis by US FDA saying that 95% of them were either not randomized or were so grossly underpowered or very poorly designed that they were not going to be useful. So on the one hand, we had good examples of ways to do trials that were really going to drive policy change. And on the other hand, we had a lot of patients being enrolled into trials that were never going to be helpful. So we clearly have examples of success, but also a big, big problem in the way that the trials were done. So the key problem statements that are really, that I focus on are, I think, threefold. On the one hand, sometimes we have funding and good processes, good prioritization design processes that lead to really important, generally international studies. Sometimes they're national, but usually international, that if they run through could well lead to generating information that could well save many lives. But at the moment we have some problems with efficiencies in the procedural framework that leads to delays. Not all of the approvals that happen sometimes you need 100 approvals. Not all of them really add anything. So how can we advance the benefits of compelling, well-designed trials through a degree of simplification of what is, in some cases, an overly complex system? Secondly, as I mentioned, many trials, and this was not restricted to the pandemic, it's clear that anyone who's involved with guidelines will know that you go through a screening process to screen the evidence that is taken up into what is then forms the basis of the guidelines process. You often screen out many, many trials as part of that process. So there's this issue that many trials do not contribute to high quality evidence. If you look at the total, if you look at all of the guidelines that are available, and this is one recent analysis in Australia, they quantified that 18%, 1/8, of all of the clinical practitioner health worker guidelines are based on high certainty evidence. Now, in some cases, we're not going to be able to generate high certainty evidence. It's not always possible to do randomized controlled trials, but we clearly could do better in having a higher proportion of our medicine decisions based on high quality evidence. And there are probably insufficient levers to prevent badly designed trials. And this partly relates to some of the incentives, where in some cases, we have small trials that are done by investigators because essentially they need to have a first author publication. And it's not always necessarily the most useful in terms of advancing science or generating social value. And then, now these first two points, by the way, are not restricted to developing countries. So if you look at a lot of the inefficiencies that occurred in the pandemic, these are absolutely were not. Access to medical countermeasures was a problem that was much greater in resource-poor settings. The problems of an inefficient system for clinical trials absolutely were seen in many, many settings, not least in Europe. By contrast, when we look at the capacity development issues, clearly there are bigger capacity gaps in some of the developing countries. So that is another big problem, and we need to ensure that we continue to advance capacities around the world, as has happened in Africa over the last 20 years during the time of EDCTP. So we have three broad streams of work. First of all, developing normative guidance, and I'll explain a little bit what the scope of this is, and some of you, we need to be clear how this relates to the other guidance that's already around. We have an external technical advisory group that has 16 of the leading experts. And also, to be clear, the scope here is all interventional clinical trials. Okay, so this is much broader than the scope of ICH. ICH, GCP, E6, the scope is very, very clear. It's for interventional clinical trials of investigational products and or interventional clinical trials that are for submission of data to regulatory authorities. Those two key scopes. Ours is any kind of interventional clinical trial. So some of these could be cluster randomized trials. There could be trials that are optimizing use of existing interventions, and they have a major scope and a major role. So we're going through a process to develop this that I'll go through. We're also doing quite a lot of mapping that we were asked to do, and then we've had a very extensive set of consultations. We were in Latin America, as Joseph said a few weeks ago, then in Lusaka with a meeting that Joseph organized with colleagues in Afro, and there's one tomorrow starting in Delhi, and then there's one next week starting in Cairo. And we're then having a global meeting afterwards because we wanted to hear from the researchers in country before we had the global meeting, and we're planning the global meeting primarily to listen to what we've heard from all of the in-country voices. Just a little bit on what we were asked to do, but there's a single now WHO clinical trials website, and the link is at the bottom. We can share these slides. It's amazing to see just how many initiatives there are. I mean, you will have seen some of the very, very important initiatives. We were able to identify 112 distinct, massive network initiatives covering cancer, cardiovascular disease, diabetes, other NCDs, mental health. Some of them focus on behavioral interventions. These are not only for medicinal products, then HIV, TB, malaria, emerging infectious diseases, and others. And some of these are focused on particular regions, some on particular diseases. Many, 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 and I've been listening into these. There are so many common themes between these different initiatives. And so I think there really is a lot potentially to be gained. Maybe this is all about accelerating and enabling and convening. The last thing we want to do is add obstacles in the path of researchers that are trying to answer questions. But we do think there's quite a lot to be gained by helping people to understand what's already been done in other areas where it's directly relevant. We also launched a public consultation. I guess I don't need to hold this, do I? This is, is that still okay? Yeah. So we put out a consultation just to ask folks what are the key areas of focus that are needed in where the clinical trial system is not working so well. And this includes all types of stakeholders, so including the private sector, who have engaged quite strongly with this. IFPMA, for example, organized their own consultation on this that they asked us to engage with, and they have sent a report to us from that. That is a really interesting report to read. It's on our website because it's a collation of what everyone is saying are some of the big issues. And I'm going to try and summarize what some of them are. We also have done some mapping with the available information on the types of trials. And this may be familiar to you all. Afro is the region here with the least numbers of trials. Yeah. So this is just to put in context the fact that even despite the fact that we've had 20 years of capacity strengthening, Afro clearly has far fewer clinical trials than everywhere else. However, I would contend, based on all of my interactions in all of the regions, that there is actually a higher percentage of high-quality, really policy-relevant trials in Afro than in some of the other regions, particularly the regions where the most trials are happening, the Western Pacific, Europe, and the Americas. And by the way, in case you don't know this, I think not everybody knows this, but we see from our global tracking that neither Europe nor the Americas are the leading region in terms of numbers of trials, and they haven't been for some years. The Western Pacific region, by numerically, overtook those two regions. Have for the last 20 years sort of had an increase in the numbers of trials between Europe and North America and the Americas. But about 5 to 6 years ago, we saw the Western Pacific region overtake those two regions, driven largely by China, but also Japan, the Republic of Korea, Singapore, Australia, and others, and general development in that region. But you see, when you look at this type of mapping, that overall neoplasms and cancer is the predominant topic of clinical trials in the world. At this kind of infectious diseases meeting, you wouldn't necessarily see that. But you also see that in Afro, the Eastern Mediterranean and the Southeast Asia region, it is infectious diseases that are the predominant topic for clinical trials. So quite a different picture depending on where you're looking. We also have been asked to map clinical trials legislation and guidance, and we identified 138 countries where we could find publicly available information on what their national clinical trials legislation or guidance documents are. And all of this is in the process of being published in a series that's going to be coming out in Lancet Global Health. And I don't know if Zoe is here from, I think she couldn't make it, she's the editor. But there's an enormous amount of information that we're going to be publishing as soon as we can. A lot of it is already on our website. When we just look crudely at some indicators for what is in the national legislation, as you'd hope to see, there's requirements for informed consent, regulatory approval, ethical oversight, but only about 2/3 of the countries that have legislation require clinical trial registration, and only a little bit more than 1/3 actually require that the results are ever disclosed. So some need for further work there. We've also, with our collaborating centre, I don't know if anybody from the Global Health Network, but they're a collaborating centre with us. They launched a stakeholder survey where we received almost 3,000 clinical trialists giving their input on what they see as the major barriers and the areas of focus needed. And you can see in this group, most of the inputs were from Afro, as well as all around the world. So this is going to be a separate publication that goes into a lot of detail on what the perceptions are. But some key points in our developing the normative guidance were that there is a lot of existing work. So we are not repeating anything that has already been done. That's the first point. And where there is really key, very good work that is directly in line with the guidance we were asked to develop, we are adopting or adapting it. And we're coordinating closely with ICH. Now, ICH is regulators with the private sector and one or two other observers with that scope, and ours is much broader. The two key documents that we were told directly relate to the scope of the guidance are the Good Clinical Trials Collaborative document, which is on goodtrials.org, which is the basis for our Section A on design and implementation in our guidance. And there's a CIOMS document from 2021 called Clinical Research in Resource-Limited Settings. That we have taken, obviously with permission and acknowledgement, as the basis for some of the other parts of this. But the other key parts are a section on strengthening the clinical trial ecosystem broadly. There's a big focus on addressing underrepresented populations, and we were asked to include recommendations on the roles of different stakeholders between funders, regulatory, ethics, researchers, patient community engagement, etc. So that's all in there. This is the timeline. We're essentially quite advanced. We completed a public consultation where we've received several hundred sets of consolidated input. Some of those individual inputs are from a Ministry of Health or a major funding agency or a university, for example. So we've received a lot of input. But the next step is going to be that we are going to be finalising this with the input with our technical advisory group. And then at that point, we'll have a very high-level WHO document, which I don't think you're going to see anything surprising in there, but it's a high-level document which is applicable to any type of interventional clinical trial. The principles in there are fully aligned with the principles in ICH GCP, both E6, E8, and elsewhere, and we are in close contact with the group that is revising E6 to make sure that there's, we can't have any confusion between ICH and WHO. But this is going to be applicable to these public health types of trials, which do not need to follow ICH GCP. And it's also applicable at a much higher level, thinking about what are the steps in the ecosystem, coordination between elements of the ecosystem. So those are some of the added value of this. And then we're going to be looking at clearly a PDF that somebody develops and it sits on our website and nobody reads has little to no value. So the key issue will be whether folks like you, when you see it as actually helpful for moving forward the agenda that you're interested in, how to generate high-quality evidence through clinical trials, and improving efficiencies in the system and developing capacities. So we really will be looking to work with any of you that would like to work with us in your area, whether it's emerging infectious diseases, HIV, TB, malaria, neglected tropical diseases, if you're working in non-communicable diseases, please, or if you're working in ICU, in hospital, in primary care, in vaccine trials, you know, we would love to work with you to think if you can implement or if any of this you can take and it can help you to advance the work in your area. And also for all these different stakeholder groups on the right-hand side, there's relevance for all of them. And just trying to wrap up or move towards the end, the key areas of focus, according to what we received, are something that's come up a lot, is how do we move away from, and I think many of you will have been familiar with this, where you have resources coming in for a project, but what you really want is to have ongoing functionality for clinical research so that you capacities are not lost when the project finishes. And I started my career a long time ago in South Africa in 1996 doing clinical research, and then worked in the Gambia for a while. And for the 5 years that I worked as a clinical trialist in Africa, you know, this was the number one issue that I had. There were a number of trials that we wanted to do that were priority, but it was all about how is the project funding coming in? Is there some way that we can move towards a bit like the REMAP-CAP trial, which was an ICU-focused trial that was, there are these concepts of perpetual trials now. Can we have, and I saw this concept in the Panther meeting. It seems very attractive that we have ongoing, sort of, some people talk about always on priority use cases in that are covering the types of data collection that you need to answer the key questions, different levels of the health system, different key disease or syndrome areas. Can we somehow support those? And can we find a framework where we don't have to have one funder funding one trial, but we have different funders funding the same functional capacity, which can then be pivoted? That, I think, would be quite transformative if we can figure out how to move there. It does seem we need to keep working on prioritization processes because, as I said, some of the limitations are not only about the resources, because there are a number of clinical trials that have been done that have not been useful. And so how can we move away from that? Part of that is ensuring that we have good scientific as well as ethical review. This is quite patchy at the moment, how the scientific review is done. There were big calls from the stakeholder survey that the Global Health Network ran for us. And the number one thing that came out of that was a little bit surprising to me was just how high up patient and community engagement and clarity about how to do that within the clinical research system. And I think one of the reasons why that came up is that some people are trained in the ICH framework. If you look at ICH E6 and you search for the word community, it is mentioned exactly 0 times. So if in ICH, there really isn't a good, there isn't any conception of patient or community engagement, actually. Whereas, obviously, there's good participatory practice, but I think building in as a normative element the fact that it is not optional to consider patient and community engagement in any clinical trial, but it has to be done in a way that is appropriate to the context. That is going to be important, and we have a number of people working with us through our community in this area in WHO that are really interested in that. There's obviously a lot of scope for newer models for RCTs, including integration into healthcare. I could talk about that a lot. Moving away from the idea that it's only some kind of clinical trial unit that is staffed with 100% professional researchers. It's only those places where you can do clinical trials. For some things, like first-in-human trials, you clearly need very specific types of facilities, but the possibility of embedding clinical trials into healthcare systems, there are major gains and already models, adaptive design, digital data collection. From what we have seen, the regulatory systems have not necessarily caught up with this, and in some places it's still required to actually print out something just because some guidance document says that it has to be a hard copy for no good scientific, ethical, or safeguarding the rights or the safety of of the participants. No actual reason other than some guidance document says that. So if any guidance says that, I would say that guidance is out of date and it needs to be updated. Clearly, improving capacities on the regulatory and the ethics side is really critical. And something that we've seen is that it seems like the support for the research ethics committees seems to be a little bit behind the support for the regulatory harmonization. And both of them, in any analysis that I've seen, when people have looked at the timeframes, what takes the longest is to set up funding. Second longest is the ethics, and actually the regulatory timelines tend to be a little bit faster. Obviously, it depends on the individual trial, but unless we think about, those three areas, having funding, ethics, capacity, support, and then coordination, but also regulatory harmonization, we will always be delayed by whatever is the rate-limiting step. The ability to have international collaborations is still a big limiting factor in some parts of the world, and actually Africa is clearly ahead of some other regions in the world. There are international investigator networks in Africa for HIV, malaria, TB, and many others. When I was in Latin America, this was highlighted as actually the number one problem that they faced, that they have very extensive clinical trial networks in Brazil, for example, but there really is there's no Africa CDC, there's no EDCTP, there's no African Union. So in some parts of the world, we really need to figure out how to answer questions internationally when we need to. And then guidance that we'll be providing on how to have appropriate coordination between different elements of the ecosystem. And various folks have also highlighted that the major delays that have come out of some logistic issues like importation of investigational products can take a very long time. And I've heard examples where this alone, for no really good reason from a scientific or ethical perspective, has delayed things by over 12 months. A lot of people have talked about the lessons learned from COVID, but I think the adaptive platform trials were underway, far before COVID. But certainly they did highlight some good aspects in how it's possible to prioritize well-designed trials, how they, in some cases, were able to have interagency coordination between regulators, between ethics committees, and between those two. And this has really advanced the concept of perpetual trials, but it's also, and some of the low-income country participants did raise the fact that there is still, some of these trials tended to be led by folks in the global north, and there is still this tendency where international trials, and I still see this all the time, even in 2023, where the middle authors will all be African, and the first author or the last author is not. So why is that? Is that okay? I mean, in going forward in 5 to 10 years, is it okay that the leadership is still going to be from the global north when nobody is enrolling? Why would we have first and the last author from a country where nobody was enrolled in the trial? But that right now is actually the normal situation. So there probably are some capacities that could be developed that could advance that. And there's also the fact that we need to address whatever are the local community sensitivities or national sensitivities. So if we're having big master protocols, how do we ensure that we have flexibilities that are needed? And we have to, this whole issue of diversity, equity, and inclusion is completely central, as well as research fairness. So we at WHO do see this as a really priority issue. And then I'm coming towards the end, but we've had so many inputs that it really does highlight some major emerging trends. I've talked about, I think, the first couple of these, in fact, most of these. AI is obviously very hot at the moment and is definitely, I will say this, it is definitely going to change almost everything that we're doing in clinical trials, as to do with everything else in health. And a lot of what is happening, I think it's quite difficult to predict how it's going to play out. I had to submit something a couple of days ago to the Lancet, actually, and I had to click a box that said, I hereby confirm that generative AI did not write this manuscript. So that's, I think, come in fairly recently to the submission process, but I think it's not going to be very long before you can say, hey, I won't say the name of the assistant, otherwise my phone will come on, but hey, name here. Here is the preclinical file, here is the toxicology data. Here is data on related molecules. Please write a clinical development program for me from phase 1 to phase 3. I mean, that will probably be possible quite soon. So how are we going to deal with that? But in other ways, we see AI massively advancing in, as I can see, only positive ways. So developing candidate interventions, drug discovery, vaccine antigen refinement, but also AI itself. We already at WHO have recommendations on specific AI algorithms in some cases. So AI to augment radiology in tuberculosis is something that we have WHO recommendations on. So there are clinical trials where the two arms are doing something traditionally and doing something in an AI augmented fashion. The other thing that people have come to us with, which I think is further away, is, you know, when will we get to the point where we just don't do clinical trials at all and we just have a simulated dossier? I think that seems to be a long, long way away. But I mean, who knows how long? This has come up all the way through, and I think this will be clear to everybody, but the fact that a lot of the frameworks that have been used until now have really focused on internal validity. So really being clear, and that means excluding often the sickest patients or certain groups, or not being able to enroll people living in remote settings. So you end up, and this is where we are right now, this is the status quo. If you look at the clinical trial data set and you look at the populations that the interventions are intended to benefit, and the resolution has very clear wording on this, they're not the same. So we're trying to make decisions about people who are not involved in the clinical trial. So what can we do to really move towards the principle of inclusion with appropriate safeguards of the people that the populations are intended to benefit? So just to conclude, we're really seeking a change towards, I have that there, towards how can we get to sustainable clinical research capacities that enable ongoing clinical research that meets both local, national, regional, and global needs. And by the time we finalize our document, after a lot of input, we will provide some guidance on the actions that could help this. Clearly, effective prioritization is going to continue to be important, addressing underrepresented populations as part of this. We also are including the concept of risk proportionality quite comprehensively throughout the document, because whatever is put in place in the context of research needs to be proportionate to the risks. And we think that if we do this correctly, it could lead to some major improvements in capacity development, but also the quality of evidence that's developed. So I think my main message for you is, as we move forward, the key point is how much this is going to be useful for people on the ground, and how the way that it is implemented can be contextually adapted to needs in Africa or in sleeping sickness or whatever the frame is. So please do contact us. We do have a team in all of the regions. Joseph is here. Each one of the regional offices are leading the consultations because they are the ones that really understand the situation in their region. All we do at HQ is coordinate between them. So once we go to the implementation phase, we're really seeking to take a back seat and allow folks in each of the regions to decide the best way to implement this and convene all of you that are the leaders in the countries and decide the best way to advance clinical trials work in your area. And I just wanted to show you this. This is just a draft. I mean, there are multiple different ways that you can frame an ecosystem, but this is all related to the concept of ecosystem strengthening and the fact that we would like to get to sustainable, strong, continuously functional national clinical research ecosystems. And I won't go through this, but I think if we can think a little bit more about how the top-down funding can mesh with the bottom-up needs, and being aware of what are the key gaps in this ecosystem in each country and to some extent regionally, then we might be able to incrementally fill in those gaps and address the sort of rate limiting issues. Like I said, one of these would be that regulatory harmonization is absolutely critical, and we fully support this. But I've clearly seen that the ethics committee work seems to be not getting as much attention for some reason, and it is absolutely as important. In fact, the ethics framework underpins everything, and it's in a way it's wrong to have ethics as one of the pillars, because the entire research framework has an ethical and a moral underpinning. I mean, everything that we do is based on the Declaration of Helsinki, if we're certainly a physician conducting clinical research. So it's that, I think, really needs a lot more work, as well as institutional capacity strengthening in low and middle income countries, in addition to researcher strengthening. And just to acknowledge EDCTP that has provided the funding together with NIHR from the UK government to allow us to do this work, and we're really very, very grateful for that, because like everybody else, we do need funding, otherwise we can't do our work. And I'd also just like to mention the Global Health Network that supported us with the survey. And if we have time for questions, very happy to take them. No, honestly, no need for... there's a microphone there. Thank you, Joseph. Okay. And there's a microphone there as well.
Thank you, Vazi, for the very clear presentation. I also want to mention that in African region we have AVAREF.
Yes, of
thanks
course.
to EDCTP.
Yes.
So thank you very much. So it's a workshop, actually,
Yes.
unlike other sessions. So here we hope to take out some things to help us enrich the guidance that we are developing. So questions here. Okay, go on, please.
Yes. Thank you so much for this presentation, and congratulations for all these efforts in putting these inclusive guidelines that will really help us on the ground. My name is Amel Zemsi. I head the Clinical Trials Unit of the Medical Research Council in the Gambia, and I have just 2 questions. The first one is the capacity development aspect for the teams to really incorporate this guideline when it is fully available. So can you speak a little bit on the model of this capacity development and how you will ensure that research team and institutions that are really interested can benefit of this fully and without any exclusion of anyone, like anybody from any country that really wants to benefit from this can really. And the second question is, some countries' legislation actually directly cite the ICHGCP as a guideline to follow. In fact, some of them is just the ICHGCP signed as the law. So what are the plans maybe to have the WHO guideline being incorporated in the country policies and legislations? Thank you.
Do you want to take a couple of questions? Or?
Okay.
Yes.
Can you write them down?
All right, go on. Just respond to that then. Respond to that.
I will, otherwise I'll start forgetting them, I'm sorry. So on the capacity development, that's probably the most important aspect. And what we would offer is that we can develop tools. I mean, this is normative guidance, but any kind of normative guidance, there's always a phase of developing tools that can assist how they are implemented. So what we hope we can do is, starting next year, once it is close to being finalized, develop online training materials on the key points that come from this, the key scientific and ethical features. So one part of it will be training for clinical researchers, but another part of it will be a tool that those working on capacity strengthening in the countries can look at and themselves, it's not for anyone else to tell them, themselves look at the framework and say, well, it looks like a next step for us in our country could be we're missing this, and how do we in our setting develop this in the best way that works for us, so we can develop tools that people in countries can use. Your second question is very important, and we have seen that there are some countries that refer to certain guidance, and I guess it's up to countries to develop their own legislation. If anybody came to us and asked us for support, even on the legislation framework. Obviously, we have a whole team, for example, supporting on tobacco legislation. And the reason why nobody tends to smoke indoors now is because it was agreed in a legislative framework discussion in Geneva, in WHO, that one of the first steps should be you ban smoking in restaurants and public spaces. So we can get involved, but that I think is another step. Maybe a first step is through the regional consultations that we can continue to have. If any of the regions decided to have a regional implementation, a specific adopted by the regional committee implementation of the next steps, then that would then lead to some very concrete discussions about what should change in terms of legislation. But it is true that in some places people, if you talk to the ICH folks, they're very clear about the scope. And we are very supportive of ICH because it's very good for its scope. But we all need to be thinking about how to avoid applying guidance, outside its very specifically intended scope.
Thank you. So we have just 4 minutes to go. If we make questions short, we may take more questions. Yes, please.
Yes, so I'm Christine Stable-Ben, Professor of Global Health from Denmark and Guinea-Bissau. I would like to mention the fact that very few trials are big enough to measure the outcomes that really matter for people, namely what is overall mortality, overall all-cause hospitalization risk. Nonetheless, I think that we have successfully, for instance, a couple of times, collected this data from many small trials that were each too small to document this effect, but where you can compile the data across trials. The unfortunate fact is that many trials, unless they're under regulatory approval and still then sometimes stepmotherly, report severe adverse events like all-cause hospitalization, all-cause mortality, because the rationale is that the trial is too small to show an effect, but disregarding the fact that if you actually have the data, again, you can compile them across data. So a very simple but major improvement would be if it was a request, an implicit fact in all clinical trials, that no matter how big or how small it was, it always should be compulsory to report all-cause mortality, all-cause hospitalization risk during follow-up, overall and by sex. So that was a suggestion from me.
Thank you.
Thank you. That's a suggestion. So let's take a question from behind. Yes, please.
Thank you. Thank you very much.
Then we'll come back to the front here.
Thank you. I'm Val Snewen from the UK Ministry of Health, so NIHR. And I just want to say thanks to Vasi for an excellent presentation, and thanks also to WHO Regions for their work on the consultation. I guess I'm interested in what the room feel about Vasi's challenge about the sponsoring institution for trials. Some of you know, because I've talked to people here already at this meeting, we've been a big funder of EDCTP trials for a while, and in previous roles I've also been a big supporter of WHO and EDCTP trials. But Vasi challenged me to ask how many of those trials are actually sponsored, in this case, in African institutions, as opposed to in the UK, for example. And actually, that's something I'm a bit embarrassed to say I'd never really thought about before. So I've just put that out to people here. You are the people who have that opportunity, as Vasi put it, to really think about in your own settings, what do you need or what do you want or what would make that happen, say, over the next X years. And then maybe we have a metric for us all to hold ourselves to account to say, well, in whatever period of time, that number has increased to whatever. And we can check it through the databases, through the registries. It is possible to work this out. So I would just like to support Vasi's efforts on this. And I'd love to hear, during the meeting, if there isn't time now, people to really step up and maybe speak about that issue. Thank you.
All right, thank you very much. Yes, please.
Remco Verleeuw from AIDS Funds in the Netherlands. I was intrigued by your slide where you showed the number of studies in the different regions. And as expected, in all regions, at least in the North America, Europe, and the Pacific region, neoplasms are the biggest indication. But there was a striking difference between Europe, North America, and the Pacific, in the sense that there were way more oncology studies in that region. So my question is, do you have any explanation for that trend? And do you see this as a regional issue, or is this something like an emerging trend that might become more global?
Sorry, I didn't quite hear. There are many more what? I didn't hear the key point.
In oncology. So there are many more oncology studies in the Pacific region rather than, or as compared to Europe or North America.
Okay.
Thank you so much. Just as a follow-up to the last speaker's question, in the number of trials across the region, there were some that are allocated to not applicable. And there were even more than from the Afro region. Are these from regions not specifically mentioned or possibly from Afro region? The reason why I'm asking is that Africa is not homogeneous. It cannot be categorized as being the same. Why some countries are very strong research base, for example, where they have long years of research experience like South Africa, the Gambia, where we have the structure. Whereas there are some other countries within each of the regions that are still struggling. So having a kind of guidelines applicable to countries who are in different level of research, experience, and development might not speak to the diversity that you mentioned. I don't know whether you are considering or you are accommodating these differences or diversity across the same region. Thank you.
Thank you. Unfortunately, this will be the last question because of time. So, Vasi, please.
Thank you. So, on the diversity, it's really very important for us to acknowledge that there's enormous diversity. And so in the way that we have developed the guidance, we've been very, very careful to make sure that it is going to be equally applicable in different settings, because it's really very high level. But that is why it's so important that we have an implementation phase, so that it's in the context that different people are working in, we can make sure that we have implementation aspects that are more meaningful, if you see what I mean. But I think one way of doing this, and one part of that is definitely the languages. I mean, this is so important. So in the survey that we ran with the Global Health Network, the large number of the inputs were in Spanish, in Portuguese, and in French. And this is just such a big issue. If we organize an Anglophone meeting, so I think it'll be really important that we address the Anglophone, the Francophone, the Lusophone, the Spanish, Chinese, etc. Another way of looking at it is a sort of, I mean, the terminology I think is not fully agreed, but something like a maturity level, which has been really accepted and embraced by the countries for the regulatory systems, where you have a framework for supporting the national regulatory authority that they take and they use because they buy into it, which has something which is appropriate when you're really just starting. You've just created the authority and you're just starting. You maybe just have a few staff. That is sort of level one. And then getting from level one to level two is a big, change. And by contrast, if you're in a high-income country, as I said, there are, maybe more relevant for this group, let's say someone like Kenya, where there are a lot of research ethics committees. They're in a very different place. In fact, in Africa, you can see still big heterogeneity between the countries. So we have to be clear that it speaks to somewhere which is really starting out, and maybe somewhere like Kenya or Tanzania, Uganda, where there's a lot of research. So we have put a lot of thought into that.
Can you also speak to
on that question? I think the question is, why is there? Well, there's a lot of neoplasm trials in the Western Pacific region, what is interesting is that we are one of the few data streams that really has information from, for example, China and every country, because it is a WHO standard system that every country submits to. So it just shows how little information we have on research ecosystems in different parts of the world. What is clearly happening is that there's a big, I think, if you're in the private sector, you can commercialize oncology work. Yeah. So there is quite big revenues to be made from work on cancer, and that seems to have really been taken up in the Western Pacific region.
All right.
Okay. Well,
So
thank you.
Thank you very much, Vasi. Please put your hands together.
Thank you.
Vasi is still very much around, at least for today.
Yeah.
So if you have other burning questions or suggestions you want to make for him, you can engage him outside here. So thank you. Thanks for coming for this session.
What?